Thank you. My presentation today is about a very important topic in pediatrics, which is UTI in children. I have nothing to disclose in relation to this presentation. So why I choose a urine infection? Because urine infection is one of the very common infections in children, and it carries a special significance. Although the vast majority of children who have a urine infection recover promptly and do not have long-term complication, but there is a small subgroup at risk of significant morbidity. And the presentation today will concentrate on identifying this small subgroup to be able to investigate them and follow them appropriately. Urine infection also is not an infection, as I said, just a simple infection. It can be a serious underlying it can be a signal of a serious underlying congenital anomaly, such as obstruction, which, if it is not diagnosed, will not only lead to serious illness, but it also can lead to renal damage. Some infections also can be associated with a progressive loss of kidney function. We have some figures to talk about the incidence. How common is urine infection? And we will talk about European studies. And we have the Sweden study. And from the Sweden study, it is reported that there is about 2.1% of girls and 2.2% of boys will have a urine infection by the age of 2. This will change with age. So a UK population-based study suggested that 11.3% of girls and 3.6% of boys will have a UTI by the age of 16. This is very similar to the NICE guidelines, which concluded that around 1 in 10 girls and 1 in 30 boys will have a UTI by the age of 16 years. Boys have a greater incidence of UTI in the neonatal period and early infancy. So there is more incidence just in the first 3 to 6 months of life, after which girls will overtake boys and they will have more incidence of UTIs. About half of the boys with UTI who presents with they will present with their first UTI before the age of 1 year, but 4 out of 5 girls will present at a later age. The incidence of acute pyelonephritis is more in girls in relation to boys, and I will talk more about the definition of acute pyelonephritis later in this lecture. Girls also experience more recurrences, and we'll talk about this more. Serious bacteremic illness from UTI is quite rare, which is a positive blood culture, and around 9 to 10 children presenting with this will be younger than 1 year and usually younger than 3 months. And that will be clear when I talk later about management of UTI in children. So as I mentioned before, girls usually are more prone to have recurrent infections, and when they have more recurrent infection, they have more episodes of UTI than boys. So 3/4 of the children presenting before the age of 1 year will have a recurrence. After the age of 1 year, roughly 40% of girls and 30% of boys will have a recurrence. We'll concentrate now about talking about vesico-ureteric reflux. So why VUR is very important when we talk about urine infection, because 1/3 of the children who have a UTI will have a vesico-ureteric reflux. So about 30%, which is a significant number. This is why when we are investigating patients with UTI, we should always think about VUR. So VUR is the passage of urine from the bladder back into the ureter and in a higher grades of vesico-ureteric reflux to the kidneys. I will just remind you of the 5 grades of the vesico-ureteric reflux, which is grade 1, which is the urine. If we look at the picture here, we find that the urine will go back just to the ureter only. In a grade 2, the urine will go back to the ureter, pelvis, and calyces, but there will be no dilatation and normal calyceal fornices. In grade 3, there is mild or moderate dilatation and a tortuosity of the ureter and mild or moderate dilatation of the renal pelvis, no or a slight blunting of the fornices. In grade 4, as we can look at the pictures again, there is moderate dilatation and tortuosity of the ureter and moderate dilatation of the renal pelvis, complete obliteration of the sharp angle of the fornices, but maintenance of the papillary impression in the majority of the calyces. In grade 5, there is a gross dilatation and tortuosity of the ureter and good dilatation of the renal pelvis and calyces, and the papillary impression are no longer visible in the majority of the calyces. What is the incidence of vesico-ureteric reflux? The incidence in general population is 1 to 3%. Severe vesico-ureteric reflux is likely to contribute to more severe representation of urinary tract infection. Vesico-ureteric reflux in girls, usually with UTI, the underlying patients, girls will have girls who have their UTI, we have 17 to 34% with an underlying vesico-ureteric reflux, and boys are similar, 18 to 43%. And this is very similar to what I said in the previous slide, which is 1/3 of patients with UTI will have an underlying vesico-ureteric reflux. Around half of children with a reflux will have bilateral reflux, and this is important in the management. In a randomized controlled trial that was looking at antibiotic prophylaxis from the USA, they found that the spontaneous resolution of vesico-ureteric reflux occurred in 37.5 in grade 1, 12.5 in grade 2, and 10.3 in grade 3. This means that the higher the grade, the less possibility of spontaneous resolution. And this is important in the follow-up of patients who is diagnosed with vesico-ureteric reflux. I'll talk more about other studies. There is a cohort study from Australia found that reflux was present in 41% of children with recurrent UTIs, but just in 27% without recurrent infection. And that will show us that patients usually with recurrent infection have a more possibility of having vesico-ureteric reflux. 32% of siblings of affected children also have reflux, but only 2% have the significant one, which is above grade 3. Mode of inheritance is autosomal dominant with variable penetrance and expressivity. How do we diagnose vesico-ureteric reflux? The gold standard investigation is the MCUG, the Micturating cystourethrogram. It provides a good anatomical detail of the bladder and the urethra. How we do it? We usually insert a urethral catheter, and then a radiographic contrast medium is installed into the bladder through the catheter. X-rays are taken, showing the bladder, urethra, and any vesico-ureteric reflux present. There is a very important point here that most people usually forget, is mainly to cover patients who's having an MCUG with prophylaxis. So they need to have antibiotics for 3 days, starting 24 hours before the procedure. So please remember, when you're arranging an MCUG as a general pediatrician to your patient, to cover them with a treatment dose of the antibiotic you choose, and that will start, as I mentioned, 24 hours before the investigation. What are the structural renal tract abnormalities in patients with UTI? The most common one is vesico-ureteric reflux, as I mentioned. The second most important one is hydronephrosis, and that accounts for about 2.5 to 7.5%. obstruction can be another important underlying pathology, and children with obstruction usually present in the first 2 months of life. The fourth common structural abnormality is a duplex kidney, and that occurs about 6 to 7% of children with UTI, and it is more in girls in comparison to boys. The other association which is very important to talk about when we are taking history from a patient with UTI and patients with recurrent UTI is to talk about the dysfunctional elimination syndrome. And the dysfunctional elimination syndrome is mainly concentrating on the bladder instability, infrequent voiding, history of constipation, because this is really important in managing patients with urinary tract infection and has an important role in prevention. And we will find that about 40% of girls with history of recurrent urinary tract infection have a history of dysfunctional elimination syndrome. This is why we should not ignore this part when treating these patients. Patients also with dysfunctional elimination syndrome may have a slower resolution of their vesico-ureteric reflex. As I mentioned before, usually lower grades of vesico-ureteric reflex resolve spontaneously on their own just with age, but with constipation, severe constipation, problem with the bladders, infrequent voiding, holding, that may contribute to the delay in the resolution and more urinary tract infections. What about scarring? Because as I said, the most important point why we're concentrating on treating patients with urinary tract infection, other than diagnosing an underlying obstruction or an abnormality, is to prevent scarring. And we usually find that about 5% of the children after their first urinary tract infection will have some sort of scarring. And then the incidence will increase more in girls when they're older because there is more incidence of urinary tract infection and recurrence. So when we're taking a history and when we're also considering investigation and follow-up for patients with urinary tract infection, we should look for recurrent UTI. So history of recurrent UTI increase the possibility of having scarring. And it is found that 73% of those with recurrent UTI have scarring in comparison to 56% of patients with their first-time UTI. The presence of vesico-ureteric reflex is also very important as a risk factor for scarring. And again, around 72% of patients with vesico-ureteric reflex will have scarring versus 52% without vesico-ureteric reflex. A typical organism, and I will talk later about definition of what is a typical UTI, and it is mainly an infection with non-E. coli organism, and that usually is more risky to have scarring than E. coli infection. Progressive renal scarring usually occur in the first 5 years of life. The following risk factors are also important when we're doing history and examination for the patient with urinary tract infection. We should be taking history about any poor urine flow that may suggest obstruction, history suggesting previous urinary tract infection or confirmed urinary tract infection. And from a practical point of view, I usually find this difficult when I have a patient that is referred to my clinic at the age of 7 with history of recurrent infection, but no results, no cultures, no clear history, and you're not really sure about was it a typical infection, was it an upper or a lower urinary tract infection. That will make investigation slightly more difficult, but you may end then over investigating the patient because you don't have a very clear history. So I think we will talk about this later when we talk about the definition, how when we have a patient with UTI that we should label it in a more clear way to help the plan and the investigation in the future. We should ask also about recurrent fever of uncertain origin, which may suggest having urinary tract infections in the past, which may not have been diagnosed. Antenatally diagnosed renal abnormality, family history of vesico-ureteric reflux or renal disease, history of constipation and dysfunctional voiding, and I did talk before about the dysfunctional elimination syndrome. In examination, we should be looking for enlarged bladder or any abdominal mass. We should be examining the back for any spinal lesion. We should check the growth of the patient. And when we do the vital signs, we should be looking at the blood pressure. And that is really important. So, as I mentioned before, when we label our patient as urinary tract infection, we should get used to have a more detailed labeling other than just a UTI. This will help the investigation, especially if we work in an environment that parents do not like, to have any invasive investigation. They're refusing cannula. They don't like their child to have a urinary catheter. So you should know if it is indicated or not. And what will help is actually labeling the UTI as an upper or a lower urinary tract infection, typical or atypical urinary tract infection, single or a recurrent urinary tract infection. So these definitions are mainly from the UK guidelines, which is the NICE guidelines, as the American Academy of Pediatrics do not actually label the patients and will not be affected investigation-wise by these. But the NICE guidelines are very clear in this label, and I will show you when we investigate the patients in the future slides, how this will be very important for arranging investigation. So what do we mean atypical UTI? If the patient, so any of these, if it is a present, you can label your patient as atypical UTI. So seriously ill, poor urine flow, raised creatinine, septicemia, failure to respond to treatment, when you're giving suitable antibiotics within 48 hours, and infection with non-E. coli organism. And as I mentioned, any of them will be enough. What do we mean by recurrent UTI? It is 2 upper urinary tract infection, 3 lower urinary tract infection, or 1 upper and 1 lower. And this is why it is important to know what type of infection the patient had. Talking now about upper and lower urinary tract infection. So from a clinical point of view, how we can diagnose the patient of having an upper urinary tract infection. So again, according to the NICE guidelines, if the patient had a fever of 38 or higher, he should be considered to have an upper urinary tract infection. Or if the patient presents with loin pain, tenderness, and bacteriuria, he should be considered to have an acute upper urinary tract infection. It is difficult sometimes to depend on ultrasound or DMSA acutely in order to diagnose upper or lower urinary tract infection, but in some countries they have a role of DMSA, but that is not in the acute management of patient, but in the UK, in the NICE guidelines, it is in the long term, not in the acute term management. What is a lower urinary tract infection? It is an infection of the bladder, cystitis, and from a clinical point of view, patients present usually with dysuria, frequency, and suprapubic pain, but we need to remember that younger patients may have non-specific presentation, and this is usually the presentation in older children who are toilet trained. On microscopy, cystitis will be the urethral, it will be the inflammation and it changes in the urethral lining of the bladder, and which will show signs of edema, the presence of inflammatory cells and bacteria adhering to or entering the cell, some of which are shed into the urine. So cystitis is the lower urinary tract infection, and it is inflammation of the bladder, and acute pyelonephritis is inflammation of the kidney. So how can we diagnose urinary tract infection? And the gold standard is the culture. But in the NICE guidelines, the gold standard sample is a clean catch. And that is easy from a practical point of view. And more than 10 to the power 5 is the cut-off point for diagnosing urinary tract infection. But according to the American Academy of Pediatrics, the gold standard sample is a catheter sample, or an SPA, which is a suprapubic aspirate. And as this sample is more sensitive and specific in detecting UTI, 50,000 is enough in the culture to diagnose urinary tract infection. So we'll talk here quickly just if you are in the ER, so what sort of sample you need to send. And the reason why I brought the sample is that there is usually a problem when we have patients with urinary tract infection that sometimes in a younger age group, doctors will just depend on the dipstick in diagnosing urinary tract infection, which is not correct. So less than the age of 3 months, you should not be depending on the dipstick at all in diagnosing urinary tract infection. Children who are younger, they don't usually test positive for nitrate because they pass urine more. So it is not actually sensitive or specific at this age group. Between the age of 3 months and 3 years, you should also be sending urine for microscopy and culture to diagnose urinary tract infection, and you should not depend on the dipstick alone. So the gold standard, less than the age of 3 years, the only way to diagnose urinary tract infection is sending the sample for microscopy and culture. And I think we should work hard to change the habit sometimes that you have a child who's 4 months that presents with fever, and they will dip the urine. It is negative for nitrate and it is negative for white cells. And then ER will decide that this is not a urinary tract infection and will get rid of the sample. Patient then will be started on antibiotic for a different reason, and it will be more difficult than after that to know if it was a urinary tract infection or not, because as you all know, 1 dose of antibiotic can be enough sometimes to clear the culture of urine. So what usually happens when the consultant pediatricians come later to do the round and see the patient, yes, where is the sample? The sample was not sent for the culture because the dipstick was negative. So this is a very important message, really, is to be sure that less than 3 years, you should be sending your sample for culture, please, in order to diagnose urinary tract infection. After the age of 3 years, you can start using your dipstick, and you can depend on the leukocyte esterase and nitrate. So if they both positive, it is highly suggestive of a urinary tract infection. So you can start antibiotics and wait for the culture to come back later. If the nitrate is positive, but the leukocyte esterase is negative, what NICE guidelines suggest is to be sure that this is a fresh sample. And if it is the case and it is a fresh sample, then this is suggestive of a urinary tract infection. So you can start your antibiotics and wait for the culture. What if the leukocyte esterase is positive? Sorry, is there a problem with the sound?
No, we can hear you fine, Dr. Sanaa.
Okay, thank you. So if the leukocyte esterase is positive and the nitrate is negative, then this can be a UTI, but can be something else. And we all know that there is a long list of causes of white cells in the urine. So this is not really highly suggestive, so you can wait, and that will be a clinical decision depending how sick is the patient. And if it is both negative, the leukocyte esterase and the nitrate, then this is not a UTI and you don't need to send a sample for culture. When you send a sample, we said in younger age group, less than 3 years, you will be sending the sample for microscopy and urgent microscopy, which will be available in many hospitals. So as you can see, this table is really very easy. I'll go through it quickly for time purposes. So if it is pyuria positive, bacteria positive, if it is pyuria positive and bacteria negative, this is what will suggest what you will do when you will start antibiotic. So the only time you want to start antibiotic is when there is no white cells and no bacteria. Otherwise, all the other results will be suggestive of a urinary tract infection, and you can start your antibiotics and wait for the culture. So what about the proper management? So you've now done your diagnosis, and the NICE guidelines divide the management to age groups. So if you have a patient less than 3 months with a possible urinary tract infection, you should be admitting this patient and starting IV antibiotics. And this will go with most of the international guidelines of fever in children less than 3 months. I would recommend, actually, if you can go through the NICE guidelines of fever less than 5 years, as it's very interesting guideline, and it does help in managing children with sepsis. What about children older than 3 months? So if the child is more than 3 months, you need then to know if the patient is having an acute urinary tract infection, an upper or lower. So if it is an acute pyelonephritis, which is an upper, then you will need to treat for 10 days. And you have the option of doing it either oral, IV, or mixed, depending on how sick is your patient. Can your patient tolerate oral antibiotic? Is the patient vomiting? And if you want to do IV, you can do cefotaxime for 2 to 4 days until you have clear culture result and you're sure your patient is well, and you can continue then the 10-day course orally at home. And the suggested oral antibiotics is cephalosporin or augmentin. Infants who are more than 3 months but have a cystitis, which is a lower urinary tract infection, can be treated by oral antibiotics for 3 days. This is according to the NICE guidelines, but according to the American Academy of Pediatrics, they suggest 7 to 10 days oral for this infection. And it is usually, again, a clinical decision, but NICE guidelines, especially in older age group, feels that 3 days may be enough. And that is usually amoxicillin or cephalosporin, trimethoprim, or nitrofurantoin. You should ask the parents to bring the child back if they're still unwell or having fever after starting antibiotics 1 to 2 days. And if the child is receiving prophylactic antibiotic and you want to treat them, we should be careful to change the antibiotic and not to use the same prophylactic antibiotic as a treatment dose, as this is a common practice, but the recommendation is actually to change the antibiotic completely and not just to upgrade the dose. The last 2 minutes, I will be talking about long-term management. So we now know we treated our UTI, but this is the part that is usually missed and is not usually standard in most of the hospitals. I won't actually recommend just following NICE guidelines or the American Academy of Pediatrics. You can follow which guidelines you like. each person should follow the country that you're living in. But if you're living in a country where there is no clear national guidelines, you should adopt one and just have a clear structure in your head how you will be investigating patients with urinary tract infection. And in the long-term management, you should know what sort of imaging you need to arrange for your patient. You should think about prevention of recurrence. I will be talking quickly about evidence behind antibiotic prophylaxis and surgery. So in the next few slides, we'll talk about investigation. And the recommended imaging is divided to age groups. So we have less than 6 months, and then 6 months to 3 years, and above 3 years. So you can notice that they will divide patients into normal, typical urinary tract infection, atypical urinary tract infection, and recurrent urinary tract infection. And you will decide what investigation you will need depending on the patient age and the classification of the urinary tract infection. And you will find that in a younger age group, especially if it is atypical, you usually should do the ultrasound within the acute illness, which is usually in the few days during admission. But if the patient is well and it's a typical urinary tract infection, then you can arrange it within 6 weeks. This is the table for patients between 6 months and 3 years. And you can notice that, again, a typical UTI is not very different from recurrent UTI. And you will find that the patient usually will need, with a typical UTI, an ultrasound and a DMSA. Another point that I'm sure you all know is just be sure you always arrange your DMSA 4 to 6 months after the last acute infection, because if you do it early, it can come back as false positive. And this is the table for the investigation for patients above 3 years of age. You will find we'll do less investigation, and MCUG is usually done in patients less than 1.5 years of age. Prophylaxis. So this is, again, is a very controversial and a gray area. When do you give a prophylaxis antibiotic for patients with urinary tract infection? And according to NICE guideline, you shouldn't give it after the first urinary tract infection, even if the patient was young. You should just consider it in some patients with recurrent urinary tract infection. So it will be case to case, depending, each patient will be evaluated separately and a clinical decision will be taken. As the NICE guidelines concluded that prophylactic antibiotics have not been shown to reduce the number of recurrent infection and can lead to bacterial resistance. Parents, carers, and children can also be non-compliant, which will cause the problem with resistance. This is the American, which is, I'm not sure if you're familiar with, but this trial has been going for the last few years. And first results came back in around 2014 or 15. And this is a randomized intervention for patients with vesico-urethric reflux, and it is mainly to look at prophylactic antibiotics in children with UTI. And what they concluded at the end of this trial, at a stage of this trial, as they keep doing it, is that the prophylaxis may reduce the risk of the UTI, but not the scarring in patient of vesico-urethric reflux. And again, this makes the prevention very difficult in patients with UTI. But how can you prevent UTI if antibiotics is not your answer? As we said, the importance of taking a good history, a good voiding history, bowel management, hygiene, asking about amount of water, drinking habits, and access to clean toilets. This is really important in the management of recurring UTI. What about surgical referral? When do we refer to the surgery? And what do we mean by surgery? It's mainly surgery for patients who are diagnosed with vesico-urethric reflux, which is usually the reimplantation surgery, or some places they will do what they call a stinger procedure, where they inject Teflon in the area around the valves of the bladder to try and reduce the vesico-urethric reflux. But again, it is also controversial that surgery is really vital. And in the UK, we just have the surgery mainly for patients who failed medical management and who are having increased renal parenchymal defects despite prophylaxis and managing and prevention and managing constipation and doing whatever you can. And it was found that the risk of renal abnormality at 5 years using the DEMSA scan was investigated in the international reflux study, where no evidence of differences were found between the antibiotic-only group and the surgical management group. I would like to thank you, and my references are mainly the NICE guidelines, as I practiced most of my pediatrics in the UK. And I've also looked at the American Academy of Pediatrics, which is interesting, but it concentrates mainly on the age between 2 months and 2 years. Thank you.
Thank you. Thank you very much, Dr. Sanaa. It's very interesting, comprehensive talk. During your talk, we received a lot of questions. I'm afraid we don't have time for all of them. But I want to start with the first one, which we received from Dr. Brizita Lazarevich. What are the genetic factors in pediatric urinary tract infection?
There is no clear genetic factors. So the only thing that I know about it from a general pediatric point of view is mainly about the vesico-urethric reflux. And as I mentioned in the lecture, there is there is a family history, and it is inherited as autosomal dominant. There is also, it depends on the pathology behind the urinary tract infection. So if you have an infection that is caused by obstruction or by another abnormality of the kidney, that will be inherited in a different way, and it depends on the pathology. But UTI, just as UTI without any underlying pathology, is not usually inherited in a clear way. But if it depends on the underlying pathology, like vesico-urethric reflux, polycystic kidney disease, what's the cause really, and each cause will be taken separately to look into the genetics of that cause.
I see. Other question from Dr. Renal Peters. Is Foley catheter insertion to measure strict intake and output is contraindicated?
No, it is not contraindicated, and we use it in many patients, especially sick children. So we do, but I'm not sure about what she means by her question exactly, but if it was done for sick children, from a measurement, we do it in unconscious children because we need to know the input-output. This is not contraindicated, but again, putting a catheter is a risk to have a urinary tract infection, but it is not a contraindication.
Right. One more question. What is the